corresponding MRI images showing the same thing, peripheral multiple cyst with central echogenic stroma, which is hypointense on star images. Another thing, when we do USG sonography in the neonatal setup, so when you do this USG in 24 to 72 hours, sometimes you might see in the pelvic system some sort of echogenic debris. You might see some debris in the bladder also. But those are because of the immature kidney and that TAM Hall's protein, which is being secreted into the pelvic system. They can cast this kind of shadows and they can be seen as a echogenic debris. So it's very important when we write this kind of debris, you should not take it as a pathology, because these are considered as physiological things during that 24 to 72 hours of initial newborn period, because they secrete that TAM Hall's protein and that will be seen as echogenic products. So that's why I was reinforcing the matter. And when we are doing USG, it has to be done by experienced pediatric sonologists who has worked for some time, so that they can avoid some unnecessary tests like laboratory tests for infection and so on. So the good ultrasound is equal to avoidance of many tests. The other question that comes to our mind, that what all we should cover when we are reporting the sonography of the KOB, and what should the pediatricians should focus in that report. So first important thing that we should mention the size of the kidney. We all know that the chart as the 1-year-old child infant will not have the same size of the kidney as the 7 or 8 years of child. So that is very important. When we are mentioning the report, we should mention the vertical diameter of the kidney, and that we can match with the age-based diameter, and then we can figure out that if the size are small or less. We should mention parenchymal thickness. We should also mention that the differentiation between the cortex and medulla is maintained or not, and we should also mention the renal pelvis AP diameter that we have talked about earlier in detail, and we should mention that ureters are dilated or not. The bladder wall thickness. The bladder wall thickness in a distended state, if it is more than 5 millimeter, it's abnormal, and we should take post-void urine whenever it is applicable. When we are seeing the cyst in the kidneys, we should focus whether there's on one side or both sides. The location is cortex or medulla, and they are diffuse or focal. So these are the things we should mention when we are typing the report for the ultrasound KUV. Important question, can USG miss the calculi? So the answer is yes, USG can miss the calculi. However, still in the present scenario, sonography is the widely used modality for the detection of the stones. Only thing that few stones which are less than 5 millimeter in size, they can be missed on USG because the small concretions, they will not cast the shadows, and we are not able to differentiate from the echogenic sinus thread. So those calculi which are less than 5 millimeter, we might miss sometimes on USD. So those kind of scenario, when we are doubtful, then we can take help of the non-contrast CT scan to detect any those kind of missed calculi. The another question that comes to our mind, that can USG pick up the VUR? That is also one of the important questions that runs to everybody's mind. So the routine sonography, neither it is sensitive nor it is specific for the detection of the VUR. So when there is a suspicion of reflux, we should always combine the USG with voiding cystourethrogram whenever it is applicated. And there are certain clues which can potentially say that this patient might have VUR, but that's not specific. For example, when you see the duplicated system in the complete duplication in the one of the kidney, when you see persistent ureteral dilatation, or when you see calyceal dilatation, those are the clues that the patient might be having some sort of reflux. So in those kind of scenario, you can do voiding cystourethrogram. Then in the present scenario, in the last decade, a lot of work is going on contrast enhanced voiding urosonographically. So they are injecting a special contrast into the bladder that produces the microbubbles, which can be seen on ultrasound. And those microbubbles, if they are going to the ureter, then in that way we can detect the vesico-ureteric reflux. However, they are right now in the research mode, and there are a few centers which have started using this technique. And the report says that the detection of the VUR, that is the vesico-ureteric reflux, with this contrast enhanced voiding sonography is on par with the conventional voiding cystourethrogram. But we need to have more practice or more experience with that to say that. Now moving on, role of MCU when we do MCU. So there are certain indications. I'm not going through all, but recurrent urinary infection when we're suspecting bladder outlet obstruction, or in a case of hydronephrosis or hydroureter, and in a case of trauma or neurological dysfunction. These are the some usual indications when we do MCU. So just wanted to show that how MCU images look. So this is the image of the full bladder, which is descended with the contrast, and that is the image in which we are showing female urethra in a voiding status, and this is the image which shows that male urethra. So the male urethra are longer; they have got two parts, anterior as well as posterior part, and we should carefully see the posterior part, because many times we see that posterior urethral valve in that posterior urethra. So we should be carefully seeing that part. This is the normal anatomy in which there is a normal distension and gentle curvature of the urethra between the posterior and the anterior. So these are the normal findings. Now I'll be showing you some sort of pathology. So this is the example of bilateral vesico-ureteric reflux, which is more severe on the left side as compared to the right side. You can see that on left side there is much more marked ballooning of the calyces. The ureter is very tortuous and dilated, and the patient also had phimosis. You can see that there is retention of the contrast during voiding near the glans penis area. So that indicates that the external meatal opening is very small. So that's why there is retention of the contrast overlying the glans penis area. So that might be sometimes a cause for this kind of vesico-ureteral reflux. So there is a grading for VUR, and usually the grade 1, 2, 3, they are managed medically, and grade 4 and 5, which are severe one, which requires some sort of surgical intervention in many of the cases. Here is the classical example of neurogenic bladder. So this is a kind of spotter images, and you can see that AP and lateral view of the bladder, which is descended with the contrast, and what we are seeing that inverted furry kind of appearance, which has got multiple circulations along the wall, and you can see that posterior urethra is also dilated here. But when you see that neck, the bladder neck and the posterior urethra angle is almost obtuse, and that indicates that there is no hypertrophy of the neck, and it's a gentle curvature, which indicates that this is not the posterior urethral valve. So I'll be showing you how the posterior urethral valve, the bladder neck and urethra looks like. So here is the example of posterior urethral valve. So they will have ideally this kind of spinning top appearance of the posterior urethra, which is dilated, and you will see this kind of circular lucency surrounding the bladder neck area. So that is indicative of bladder outlet obstruction and bladder neck hypertrophy, which is leading to this kind of appearance. Here the angle is kind of acute with the bladder neck, not like obtuse as we saw in the previous scan. And you can see that there is a caliber change of the urethra. The anterior urethra appears very slit-like, and this patient also had poor stream. So these are the all findings which gives us confidence that this is looking like more of a posterior urethral valve. Sometimes if you do the VCUG carefully, then you have to see that where the ureter is inserting. So here we can see this is an example of ectopic ureter in which the dilated tortuous ureter was inserting in the urethra. You can see that this is the posterior urethra, and that is the membranous ureter. Somewhere near the membranous urethra, the ureter was inserting here. That is seen on the oblique images also. So we should carefully see where the ureters are inserting, and that's why we take the oblique views to look at whether they are inserting at normal view junction or they are inserting somewhere else in the urethra. It is very important when we are doing the VCUG, we should document the early phase also, because small filling defects, if we don't take in the initial phase, that can be easily missed. And this small filling defect can be a ureterocele. So if you don't pay attention properly and you just take later images, then you might be able to miss those early features of ureterocele, which will be seen as a filling defect in that partially descended bladder. This patient also had this kind of VUR that is seen here, and these are much more images of the same patient. The ureterocele was confirmed on USG. You can see that this nice cobra head appearance of that balloon dilatation of the lower VU junction, and the patient also had hydronephrosis that we can see here. Then what is the role of IVU in current scenario? So in the current scenario, we are not using much IVU. It has very limited role, and that has been mostly replaced with the cross-sectional imaging in the present scenario. So we are not doing much IVU today's era. Now moving on to the cross-sectional imaging. What is the role of CT? So CT is useful because it will give you the 3D anatomical information. It is definitely useful for the blunt abdominal trauma in which we want to grade the severity of the trauma to the urinary system. It will be useful for the detection as well as follow-up of the ureteral calculi. And the CT has two kind of studies. One is CT angiogram and one is CT urogram. So as far as the urinary system is concerned, CT angiogram is useful for the donor evaluation in a case of transplant workup. It is useful for the renal hypertension, vasculitis, or any vascular malformations or a traumatic aneurysm. Those kind of findings can be picked up on CT angiogram. And CT urogram, which is more focused towards the parenchyma and the excretion. Those kind of study will help us in assessing the congenital anomalies. Is there any obstruction or trauma to the system? That can be easily picked up by CT urogram. For example, if there is any trauma of calyces or pelvis, then it will show contrast exacerbation in the delayed phase. So that will be picked up on CT urogram delayed images. So those kind of things will help us. So here is one child. Just wanted to show some few case examples how CT helps. So 8-year-old child who had recurrent urinary infection, and what we are seeing here that generally the renal hilum is placed medially towards the psoas muscle, but here you can see that both kidneys are showing the renal hilum, that is the renal pelvis area. They are facing anteriorly on both sides, and if you see carefully that there is some sort of bridging parenchyma between those two kidneys. So when you see this kind of bridging parenchyma at the lower pole of the both kidneys, in the midline, which is anterior to the aorta, that is the horseshoe kidney. So in a case of horseshoe kidney, why we do CT scan? When there is some sort of complications in the horseshoe kidney. For example, if the patient is having recurrent infection or the patient has gross or moderate kind of hydronephrosis and you want to do something for that, those kind of scenario, you can do the CT scan. And these are the representative images. Here is one more example of a duplex system. So here is the both in the left kidney which has got this kind of upper moiety, and that is the lower moiety, and the upper moiety appears more dilated, and the lower moiety ureter is inserting into the common ureter at the mid part of the abdomen. And the interesting part in this case was that both the ureter, they were not inserting into the bladder. Just wanted to show images. Yeah, so this is the 3D rendered images, in which we can see that this is the bladder, and those are the bilateral ureter, which were not inserting into the bladder. They were inserting somewhere else, either in urethra or vagina. So this kind of information can be given by CT scan. But if you want to focus with more resolution, then you can go ahead with the MR urogram also, especially if you want to see the exact insertion of that ureter, whether it's in vagina or urethra. Those kind of details, MR has upper edge in comparison to the CT. So in those kind of scenario, you can use the MR urogram also. Calculi, we have seen that radiodense calculi can be easily picked up, which are missed on USD. And here is one example, that one radiopaque dense calculus, which is near the right side of the VU junction. The urinary system also includes the adrenal. So the adrenal lesions can be managed by doing either CT or MRI. Here is one of the case in which the patient had incidental detection of left adrenal lesion, which was having calcification, and that was intending on the kidney. The patient actually came for the antenatal hydronephrosis on the right side. And on follow-up, we could find out that the patient had on USG picked up that there was some sort of incidental lesion, so that we went ahead with the CT. And that showed that the patient had this kind of flat adrenal lesion with calcification, which turned out to be a neuroblastoma. So these kind of adrenal lesions can be characterized by either doing CT or MRI. Moving on to the role of MRI. So nowadays, in a pediatric population, due to radiation concern, the role of MRI is increasing, and because it gives us anatomical as well as functional information. And the applications are as same as the CT if you want to evaluate congenital anomalies, obstructive lesions, and especially when you have complex congenital genitourinary problems like cloacal abnormality, or you have some sort of ambiguous genitalia. Those kind of scenario, MRI should be done at least the pelvis part of the MRI, because they have a very good soft tissue resolution, and we can identify which structure is what with great confidence, in which sometimes CT lags behind. So these are the MRI urograms, a few images in which we can see that this patient had some sort of left-sided PUG obstruction. Now we do MRI for this kind of patient because of the surgical plan. because we need to see that where is the orientation of the pelvis, whether the pelvis is oriented anteriorly, laterally, medially. That is very important for a surgeon to plan the treatment. And at the same time, if you give the contrast, and contrast will be excreted, and that will give us some sort of functional information of that kidney also. Here is one of the indication in which we do MRI is that whenever there is we are not feeling the testes in the scrotal sac, and the USC also not able to localize. In those kind of scenario, MRI has better sensitivity in picking up. So here is one of the case in which the right testis was not seen in the scrotal sac, and when we did the MRI, we could see that the testis was somewhere near the upper part of the inguinal canal, near the inguinal ring. The left testis was in normal location that we can see on this coronal as well as axial images. So testicular localization also can be sometimes done for the by the MRI. MRI definitely has role for the ambiguous genitalia or disorder of the sex development. For example, here is one of the female phenotype externally. The MRI was done in which there was absence of uterus, and what we could see that testis looking structures were seen in the abdomen. So this kind of detail MRI gives us, in which sometimes the CT scan may not be able to differentiate or may not be able to tell confidently. So whenever we are dealing with this kind of ambiguous genitalia, we should do USC and if required MRI. One more point is that we should not limit ourselves by only one modality. Whenever indicated, we can go for another higher modality also, just to solve the clinical doubt. Here is one of the another complex case of cloacal malformation in which patient came with some dribbling of urine. And what we could see that the ureters, they were inserting in the vagina, and we can see that there was some sort of air in the vagina. And these are a few more images in which we can see that this is the bladder, that is the lower ureter, and those were inserting into the vagina. The patient also had air in the chalasis, so that indicates that the patient had some sort of bowel communication with this complex cloacal anomaly. So these are some indirect hint that we'll pick up on while doing the MRI. A few words for the genitogram. So the genitogram, initially we can do just to see that how much is the length of that common channel. Because if the length is short and the length is long, based on that, the surgeon can determine what we should do. So here are a few examples of that common channel of a different length, and opacification of genital organs as well as the bladder that we can see here. Now, the last one is the nuclear imaging. So nuclear imaging, it consists of our renal scans, that is DMSA and DTPA scans. So the DTPA scan, that is basically used for the function of the kidney. And the report says individually the right and left kidney, how they are functioning. And in that way, we can see that is there any site of blockage that can be identified in a case of huge obstruction. We can also measure the GFR, and we can evaluate the flow through the pelvic system into the ureter and bladder. So these are the advantages of using DTPA scan. And the other scan is DMSA scan. So DMSA scan, it is used to check the structure of the kidney, size and shape. And it can also use for the location of the kidney, whether it is ectopic or not. And in a case of scarring due to recurrent urinary infection, you can use the DMSA scan. So here is the example of DTPA scan in which one of the patient had the UJ obstruction, and there was differential function in the kidneys, which was evident by this DTPA scan. And this was the example of DMSA scan, in which we can see that one of the kidneys shows these kind of focal areas of reduced uptake, which indicates scars in the kidney. So that also can be better picked up on DMSA scan, and these scars can be secondary to VUR. So the last point is that how we evaluate the pediatric renal masses. So basically, USG is the initial modality for any renal mass, and USG will help us from where to biopsy. CT, MRI, they are needed for the loco-regional spread as well as staging of the mass. And PET scan also can be done for the same in certain scenario. And bone scan sometimes can be done if you are suspecting bony metastasis, for example, clear cell sarcoma. So these are the imaging modality, and the XHS can be done for the follow-up of the chest metastasis and during the early evolution. So these are the things we can do during the renal mass. Here are two examples of renal and suprarenal mass. So here is one case in which the patient had bilateral whims, And CT and MRI, due to their 3D anatomy, gives excellent imaging resolution that we can identify the organ of origin, and we can probably say that this looks like more likely to be a renal mass than the other mass. And this was the case of neuroblastoma, in which we could see that the patient had mass with calcification, and the kidney was displaced inferiorly. So by these imaging features, we can say confidently whether it's a renal mass or extrarenal mass, and CT MRI scores higher in this kind of scenario. So the take-home message of my today's presentation would be that a good ultrasound by experienced sonologist makes the life easier, and we should know the pros and cons of each modalities, and we should select the modality pertaining to the clinical question, and we should save the radiation whenever it's possible. Whether the clinical question can be dealt by MRI, then we should do MRI instead of CT. And in a case of complex case of cloacal malformation or genitourinary conditions, we can be a generous approach, and we can use 2-3 more imaging modality either simultaneously or at an interval, just to come up to conclusive evidence. So thank you so much. By that, I would like to conclude my sessions. If any questions are there, I'm happy to answer. Pardon, sir? Max scan is similar to the DT-based scan only. That will also give you the function, and that will also can be sometimes used for PUJ obstruction, those kind of things. Anything else? Anybody from those who are in remote location? Okay, then if we don't have questions, then we will move ahead. I would like to invite Dr. Amrish Vaidya. Dr. Amrish Vaidya is our senior pediatric surgeon who has major interest in urinary tract imaging. He needs no introduction, and we are privileged that he is with us to share his vast experience in pediatric urology conditions. So I would like to invite Dr. Amrish Vaidya.
Good afternoon to all of you. My talk today will be in the neurogenic bladder. Now, hello, am I audible? Uh, my talk today is on the neurogenic bladder. Now, we've already have had extensive talks on different aspects of pediatric urology, including the talk that Dr. Nisha gave, the excellent and very comprehensive talk on voiding dysfunctions in children. Neurogenic bladders and voiding dysfunctions have a lot of overlap, and there are subtle differences between them, and which we will hope to highlight here. So again, just to briefly recap what the bladder is and how it plays a role in micturition. As far as we are concerned, the important thing that the bladder does is that it must be able to store urine effectively and it must be able to void urine effectively. Not only that, but when it stores urine, it must store urine in an adequate capacity, which is appropriate for age. And this storage of urine must be at a low pressure. And we'll see in a little bit what this means. When this bladder voids urine, the voiding must be initiated at full capacity of the bladder, and the void must also be a low pressure and a complete void. Now, as far as storing urine is concerned, we all know that there is a formula which tells us roughly what the bladder capacity should be. We are also interested that when this bladder is expanding to store this urine, this bladder is compliant, which means that it stretches easily. It's an elastic bladder. This bladder is generally under central control, which allows us to void at will, and this maturation happens through childhood as the child grows older. In between this, the detrusor must be relaxed, and the external and internal sphincter must be closed so that this child can hold urine properly. That voiding, which should happen at capacity, should happen as one complete void. There should not be any leaks. There should not be any interruptions. The void should be a full void, and it must be a low pressure void. The detrusor contractions are set up when the bladder reaches full capacity. And when the detrusor contracts, the internal and external sphincter should relax. This is very obvious because as the detrusor contracts, the outflow of the bladder must be relaxed to allow the urine to flow out smoothly. Now, when the bladder is empty, this is looks like a very complicated picture, but what we are trying to say is that there is a whole lot of neural control that the bladder has. And when we try and differentiate neurogenic bladders from voiding dysfunctions, what we are trying to say is that in neurogenic bladders, the entire control mechanism of the bladder is at fault, whereas in voiding dysfunction, it is the bladder muscle which is at fault. A lot of the manifestations are similar. Maybe the treatment is also similar, but it's very important to identify what the cause of the bad bladder function is. And this again shows that when the bladder is full and voiding has to be initiated, then there are several centers which come into play, including the cerebral cortex, the spinal center, and finally the peripheral nerves. Our implication in all this is that a malfunction of any of these can actually cause a neurogenic bladder. So again, this is a picture that shows the neurophysiology of micturition, but we'll skip over this. Get down to defining what a neurogenic or a neuropathic bladder is. So neurogenic bladder or a neuropathic bladder is bladder dysfunction due to disruption of its neural control. Generally, voiding dysfunction is bladder dysfunction due to an inherent problem in the bladder detrusor itself. Now, this disruption of the neural control can be central, meaning cranial, as in conditions like cerebral palsy or intracranial tumors. It could be spinal. The commonest that we see is spina bifida and sacral agenesis, but spinal cord trauma can give rise to the same thing. Iatrogenic, we've seen patients where inadvertently chemotherapeutic agents have been injected within the spine instead of outside the spine, and this has caused permanent damage to the spine and caused neuropathic bladders. Spinal cord tumors can cause a similar kind of situation. Pelvic surgery or surgery for anorectal malformations, which may damage the peripheral nerves as they run to the bladder, can also cause a neuropathic bladder. Now, all of us have seen this classification of neurogenic bladders in our textbooks, where bladders are called either automatic bladders or autonomous bladders. And there are all kinds of implications of these. This is a good academic classification, which is interesting when you have to write an exam paper. We are now clinicians and we are interested in treating these bladders. And I personally find the old classification cumbersome, because what I am interested in when I see a patient is, can the patient store urine properly, or is he not storing urine properly? Can he void urine properly, or is he not voiding urine properly? And my treatment is going to be aimed at setting right his voiding dysfunction because of a neural condition. Also, when a child is voiding or storing, is he storing at a high pressure, or is he storing at an adequately low pressure? The implication of this is that when we measure the pressure, and it's been found statistically that if the pressure in the bladder goes more than 40 centimeters of water, then this pressure is transmitted to the kidneys and is detrimental to the kidneys. One more reason for, say, giving up the old academic classification is that in real life, things don't necessarily happen as they do in pathology specimens. And especially in cases of spina bifida, there can be a mixed picture of voiding dysfunction. And what the net result is on the bladder is what really matters to us as clinicians and as people who treat these. So when we say that there is a failure to store urine, on the left, you see all the conditions which enhance proper storage. And on the right, we see things that go wrong. So to store urine, you need a relaxed detrusor. So if the detrusor is not relaxed and is an overactive detrusor, it will trigger contractions inappropriately, and this bladder will not be relaxed and be able to store urine. In order to store urine, the tap has to be closed. The external and internal sphincter both have to be closed. But if these sphincters are open because of a lack of nerve supply, then again, even if the detrusor is relaxed, this bladder will not be able to store urine adequately. So in an overactive detrusor, as we've said, that detrusor contractions are triggered at very small urine volumes. You might recollect that Dr. Nisha spoke about the same condition. This can happen as an inherent problem of the detrusor, or it can happen because of faulty nervous control. Now, there's one more catch to this. When the detrusor contracts, if the sphincter or the outlet is open, then this is called a synergic contraction. What will happen is that the detrusor will contract, the sphincter is open, and the urine will be thrown out. That's something that's going to cause incontinence, but it won't cause very high pressures to be generated. However, if these sphincters are closed, then very high and dangerous pressures can be generated in the bladder. If the detrusor is areflexic, if the detrusor just doesn't contract, similar to an underactive bladder that Dr. Nisha spoke about, where the bladder is stretched beyond capacity and loses its ability to contract, then these bladders are large, flabby bladders. And if they have closed sphincters, then these bladders will not empty out urine properly. So failure to void can be because of an areflexic detrusor, which causes overfilling of the bladder. And once the bladder is overfull, at some point, the capacity of the bladder will be reached and a little bit of urine will keep leaking out. And this is something called overflow incontinence. If this child is sent for a sonography, then they will report to say that the bladder capacity is so much. After the child voids urine, there is a very large amount of residual urine left behind. Now, again, Dr. Nisha has already stated that voiding dysfunctions and neurogenic bladders are associated with constipation. One affects the other. We must remember that besides sharing a common nerve supply, physically both the bladder and the rectum occupy the same space in a closed pelvis. And when one is overfull, it will always affect the other. Now, why are we so concerned about neurogenic bladders? Sure, they cause incontinence, and that's something which is embarrassing. It's socially not acceptable for the child. But we are interested in neuropathic bladders because bladders which are high pressure, transmit this pressure to the kidneys. They can cause reflux. They can cause hydroureteronephrosis. They can ultimately cause renal damage and kidney failure. And if these bladders are not treated, then there is urinary tract infections. If there is vesicoureteric reflux with urinary tract infections, then this can cause renal scars. And this again is not healthy for the child. So our clinical approach in all this is, once we diagnose a neurogenic bladder, we want to identify which bladders are dangerous high pressure bladders and start treatment on those immediately. And as this child grows up and is able to get a sense of social continence, then we are interested in treating those bladders which are not so dangerous. So presentation of many neurogenic bladders is at birth. It can happen along with or follow the surgery for spina bifida or sacral agenesis. And in infancy or childhood, as we said, when there is surgery for anorectal malformations, you would look for a neurogenic bladder. You would look for a neurogenic bladder when there are lower urinary tract infections, incontinence, repeated urine infections, or children who come with renal failure. Now, on examination, besides findings in the general examination that tell you that all is not well with the child, on neurological examination, you will find features of the underlying condition, like an examination of the spine. In this picture, you also see that besides the spinal cord, the spinal dystrophism, this child has a very patulous anal sphincter, which points to the fact that the nerves have already been affected, and this child is definitely going to have a neurogenic bladder. On abdominal examination, a palpable bladder, an expressible bladder. This means that this bladder is storing urine and is unable to void. Sometimes these bladders reach such high pressures that it actually opens up the uricus, which is a connection which must otherwise be closed. Here, a child has presented with a purulent discharge at the uricus, and that pointed to the fact that he had a spina bifida occulta and a neurogenic bladder. Of course, you check the spine, the hernial sites, you would check the condition of the perineum and of the anus, and you would do a quick local neurological examination for their local reflexes. These are all the routine investigations that you would do. We've already been through the imaging that Dr. Hiren has spoken about. And these are the various tests that are generally recommended. Usually an ultrasound and an MCU are absolutely mandatory before we start any treatment for a neurogenic bladder. We've already seen with Dr. Hiren previous pictures of what neurogenic bladders look like, but these are some more pictures. This bladder is typically called the Christmas tree bladder of a neurogenic bladder, which is a large elongated bladder with lots of trabeculations. You would have a large amount of post-void residue, and if you did an MRI of the spine, there will be a spinal lesion which will point to the fact that there is a spinal condition which has caused this. Now, urodynamics is another useful study in neurogenic bladders, which we have started doing at our institution. And urodynamics is a study of bladder function. What basically is done is that a small catheter is introduced in the urinary bladder, which can both fill the bladder as well as sense the pressures within the bladder. So what we do is slowly fill the bladder to simulate the act of a bladder normally filling, and simultaneously take pressure readings to see what kind of pressures this bladder generates. And we will then see what the bladder capacity is like, how easily distensible the bladder is, what pressures are reached in the bladder during filling and during voiding, and how much volume is retained in the bladder before leakage happens. All these are important parameters to help us to plan the treatment. They're important for prognosis and also for gauging therapy response. Uroflowmetry, on the other hand, is the study of the flow of urine, where a child voids into a bucket, but this bucket has a sensor which can tell us how fast the urine is flowing, and it gives us a chart which measures the urine flow versus time, and that helps us in many ways to do an early identification of a neurogenic bladder or a voiding dysfunction without it being an invasive test. Cystoscopy is very important. On the left-hand side, you'd see a child who has a normal cystoscopy. This is what a normal detrusor looks like. On the right-hand side, you see a child with lots of trabeculations and detrusor hypertrophy. Why does detrusor hypertrophy occur? It's similar to people going to the gym and doing resistance training to build up their muscles. When a detrusor keeps contracting against a resistance, which can either be a closed sphincter or an anatomical resistance, the muscle fibers of the detrusor hypertrophy, and then you get that kind of an appearance, which suggests that you need to look further as to what the cause of this is. Now, many years ago, there was a pediatric surgeon in the UK who had described a typical child with spina bifida as a paraplegic, incontinent cripple snatched from the jaws of death in the neonatal months by repairing the meningomyelocele, only to be delivered over to the tragedy of an expanding head, a hydrocephalus, or to a life of social exclusion in the fumes and filth of double incontinence and trophic ulcers. Now, it's very sad, but in a lot of our centers and small towns today, this is still the condition of children with spina bifida. They are still children whose urinary problems are not adequately dealt with and who are leading lives of isolation because of restricted mobility and incontinence. So the aim of therapy is, of course, to deal with this large social problem of keeping the child dry, but also to prevent urinary infections and prevent renal damage. And there are some broad therapeutic options. Again, a lot of these will overlap with the treatments that Dr. Nisha has already spoken about. But our aim is to modify the voiding patterns to suit the lifestyle of the patient. There are certain drugs and medications that can be given. Clean intermittent catheterization, which is perhaps the most important form of treatment for these children. And lastly, surgical options. So let's get down to drug treatment, because that is a little more important than lifestyle modifications, which is a little more to do with voiding dysfunctions. And there are various categories and classes of drugs which work on the bladder, which you might want to use to try and enhance either the emptying or the storage of the bladder, depending on the case. But I want to dwell a little bit on CSIC, which is clean self-intermittent catheterization. So what is CSIC? CSIC is clean. By clean, we mean not sterile. So this is something that can easily be used at home by someone washing his hands with soap and not necessarily sterilizing catheters. Clean self-intermittent catheterization. As soon as the child learns to be independent, this is something that most children with neurogenic bladders can do. We've had children as young as 6 or 7 years perfectly doing their own CSIC and managing themselves. Intermittent is generally every 4 to 6 hours. It avoids the problems of continuous catheterization, of which there are a lot, and it allows the bladder to fill and empty. This cycling of the bladder is extremely important to try and preserve whatever functional capacity the bladder has. And the catheterization is, of course, insertion of the tube by self or a caregiver for just long enough to completely drain out the bladder. So in a CSIC, what happens is either the mother or the child himself or herself will insert the catheter into the urethra till the urine flow starts. All the urine is allowed to empty spontaneously into a container. And as soon as the urine flow stops, this catheter comes out. It's been found that properly managed, a child can achieve dryness for between 3 to 6 hours if this catheterization is done. If there is no post-void residual urine, since the bladder is emptied completely, the chances of infection are less. And socially, the child is just fine for the next few hours to go and watch a movie, to go for a game and play with friends, to take a long train journey or bus journey, or to sit through one session of school, so that before school starts and in the break, he can go and catheterize himself or herself. So the principles of CSIC are that bladders that store urine at high pressures, or bladders that void urine at high pressures, or bladders that don't empty completely, we don't allow them to get to this situation. Before all this happens, the catheter is put in, and this catheter allows a low pressure emptying of the bladder. When is CSIC started? Actually, it's best started in the neonatal period. If there is a child with spina bifida whom we see in our outpatient clinic or in the hospital, we teach the mother how to do a CIC at birth. When the child does CIC at birth, he grows up thinking that this is a normal way to void. It doesn't become a big traumatic thing. When the child is a baby, it's much easier for parents to carry out a CIC, and it's just taken as a matter of course. When we counsel parents about CIC, it's important to tell them that yes, the child is not voiding normally, but as far as they are concerned, they should impress upon a child that as other children go to the toilet to pass urine, this child will go to the toilet to catheterize himself or herself. And this is the normal for this child, something that has to be carried out throughout the child's life, and most of them lead perfectly normal social and professional lives if they are adept at CIC. So how often? We already said initially every 3 to 6 hours. It has to be individualized. CIC is not done during the night. The last catheterization happens when the child goes to sleep, and the first one as soon as the child wakes up. And the medical benefits of a CIC are decreased infection rates, decreased pressure generation, less renal damage, improves bladder compliance, and it heals skin ulcers because there's no wetness all the time. There is better control, often complete dryness. There's no smell, fewer pads, diapers. It allows social interactions, travel, better hygiene, and a sense of achievement and great freedom for the child. So there are, of course, difficulties of a CIC in a male versus a female. In the male, since there is a pendulous penis, accessing the urethra is much easier than in a female. In spite of that, a lot of females learn how to do this perfectly well. Again, to come back, before CIC, children often report frequent and severe infections, difficult to treat residual urine, upper tract infection, late detection of mild infections, and difficult to obtain clean specimens of urine. And all this becomes possible after CIC starts. So CIC is something that we start with in almost all children, but there are certain conditions in which CIC is not successful, in which case surgery needs to be done. And this surgery, as in all our treatment modalities, the aim of surgery is to save the kidneys from infection or damage when there is a failure of conservative therapy. Now, the success rates of sports are between 40 to 85%, but in those which are left over, then a surgical option can be done. Principles of surgery in neurogenic bladder are to restore the capacity and compliance of the bladder. Some of the bladders and neurogenic bladders, having been neglected through early life, are extremely non-compliant, meaning very tight, small, inelastic bladders. These bladders don't have any capacity to expand. And if they don't have a capacity to expand, you have to do the capacity of the bladder. Some children are born with sphincters which don't work at all. So even if the bladder is elastic, this bladder can't store any urine. So sometimes we have to intervene to tighten the sphincters or to tighten the bladder neck in certain ways to allow this bladder to expand and function a little more properly. In very small children, if CIC is just not going to be possible, we do an operation called a vesicostomy. Now, a vesicostomy is, as you see in this child, where the bladder is brought out on the skin and urine flows out continuously through this bladder. At this age, normally children wear diapers, and this vesicostomy will drain continuously into a diaper. With a vesicostomy, there's no residual urine, there's no pressure generation in the bladder, and therefore no reflux. So it's an extremely effective way of tiding over the first few years when other methods are not possible. So when there is a small capacity and non-compliant bladder, we do an operation called an augmentation cystoplasty, which is we augment the capacity of the bladder by adding a piece of either small intestine or colon, which is patched onto the bladder to increase its capacity. This creates a large volume reservoir to store urine, and this allows less pressure to be transmitted to the kidneys. Another method which has gained popularity is to give a Botox injection within the detrusor. If we give an intravesical Botox injection, sometimes an overactive or a highly active bladder can relax and allow a little more capacity to develop and allow better storage of urine. So while augmentation cystoplasty is a very major surgery with a long hospital stay, intravesical Botox injections can be done on an outpatient basis. The disadvantages are that it doesn't work in all patients, and even if it does work, then it's effective for about 8 months to a year and then needs to be repeated. But a lot of patients opt to come for yearly Botox injections and avoid very major surgery. In case we need to increase the resistance of the outflow, we can do this either by augmenting the bladder or by adding something which is called a facial sling, which tightens the bladder neck from the outside. So all these are measures that can be used to replace what doesn't work very well in the bladder. And finally, we have a very interesting operation called a Mitrofanoff operation. Now, what happens in a Mitrofanoff operation is that the appendix is taken on its pedicle, and one end of the appendix is attached to the bladder and the other end comes out on the skin. What this allows the child to do is to not be bothered about accessing the urethra, which is sometimes difficult in female children. But there is a small opening, just like the umbilicus, which is created on the abdominal wall. And so without the child getting up or going and sitting on a commode or otherwise moving around, sitting in that wheelchair, a child can catheterize himself or herself and have very easy access to the urinary bladder. So similar principle is used to do what is called a antegrade continence enema operation. A lot of these children, besides having a neurogenic bladder, also don't have any control over stools. Now, the usual way to manage this is by administering enemas to these children daily or once every other day. Administering enemas to a disabled child who might be obese and on a wheelchair is something which is difficult. So here we bring out the appendix without disconnecting it and connect it to the abdominal wall so that from the appendix fluid can be introduced, which irrigates the whole colon. And when it irrigates the whole colon, the entire colon becomes empty. This whole process takes about 1 to 1.5 hours. And once they are done with it, then for the next 48 hours or so, they're completely dry. So this is also another very, very effective surgical option that we have to treat patients with neurogenic bladders and neurogenic bowel dysfunction. Besides this, there are other forms of surgery which are done at the neurosurgical level, because remember that all these bladders are bad bladders because of their nerve control, and certain neuromodulation by implantable devices have been tried. Certain operations to divide certain spinal nerves have been tried, all with variable results. We as urologists and pediatric surgeons like to treat the symptoms, like to treat the bladders rather than the nerves. So this is in brief about the neurogenic bladder. It's slightly more complicated than voiding dysfunction, but both voiding dysfunction and neurogenic bladders start out their treatment together. They only diverge a little bit because in a neurogenic bladder, the effect on the bladder may be a little more severe than it usually is in a voiding dysfunction. Thank you so much, and I'm happy to take any questions. CIC is a lifelong thing. So there are lots of people whom I know now in my practice. Say I've started teaching CIC for the last 30 years or so. There are people who are in college who are doing jobs. Recently, a very heartwarming thing for me was that a child who's mobile but on CIC has just registered for a course in the UK. She's gone ahead and got admission, and for the first time, she's going to be leaving home and flying out herself. And she needed medical certificates to carry a whole lot of catheters and other things with her. So I think once this process is well set, they don't get infected. It means interrupting their lives every 3 to 4 hours for about 5 minutes, which is what any other person may do to use a washroom. But yes, they are in college, they are in relationships, they are in jobs. I think they manage fine. And once CIC is started, see, another very interesting thing in neurogenic bladders is that since the lower part of the body doesn't have a nerve supply, generally the perineum doesn't have any sensations. And so when they do a catheterization, there is no sensation when they're putting in the catheter. So for them, it's relatively easier. And like I said, once they started, they never want to not use it because it just is a life-changing thing for them. I don't see any questions on the chat either. So
yes. Thank you, sir. like to thank Dr. Amrish Vaidya for that wonderful talk. Our next speaker is Dr. Sachi, who will be talking about the psychological implications of avoiding disturbances. Dr. Sachi is a psychologist and art-based therapy practitioner with a PhD in psychology, working in the space of child and adolescent mental health and psychosocial care for almost more than a decade. I'd like to hand over to Dr. Sachi.
Was here.
Hello, everyone. Thank you for the kind introduction. And I think Sir's presentation covered many aspects of, psychological implications and management as well. I'm just going to elaborate a little more in this space. So what research says is definitely the areas that are impacted most by the condition and the management of CIC and self-catheterization is physical, social, and psychological. And results have shown that children and adolescents are able to manage quite well. But when it becomes a focus and the main focus of their life or the family, that is when there is a strain in relationship. So expanse of impact when it comes to psychological and mental well-being, definitely it has an impact on the self-esteem, on the body image. There is isolation and withdrawal. There is anxiety about adapting, and also the management part of it. There are depressive feelings because of the shame or guilt that the child experiences, or the isolation or the withdrawal, or the challenges in management that the child experiences in day-to-day living. And definitely there is an impact on academic problems and school problems. There are some research which says that quality of life tend to be impacted more with age. Again, this comes with a clause if the adaptation and management is not followed up well since the time the condition is being diagnosed. There is definitely an impact, larger impact on the family. where there is added strain of care. Parental acceptance and adaptation has a huge impact on how the child is subsequently going to adapt to the condition and management of CIC, and as well as how he's or she is going to receive the support in the space. There is parents' mental health and stressors and triggers that need attention. Definitely, there are times when, there's lack of support or there is social withdrawal among the families. And if there is stress on marital relationship of the parents, it makes it even harder to function as a family. Studies have indicated that major brunt is mostly on one parent, especially the mothers, because they are the primary caregivers in most scenarios. What matters most is psychoeducation and the support that is provided to the family from the diagnosis to continued follow-up and management of the condition. It's important that this treatment or the management becomes a function of multidisciplinary team. And great success can be only achieved, if all the professionals involved in care are functioning in coordination. Some of the challenges that are observed in care are the complexity and intrusiveness of the treatment, the chronicity and the chronic nature of it, presence of additional functional impairment or disability that may go along with these conditions, family support resources, again, if there is difficulty in family adaptation, socioeconomic conditions, definitely. Since there's one more important aspect where we as clinicians or practitioners and a part of the team would need to be sensitive to the level of responsibility that children are feeling ready to take for their self-care and the transition of care from parent to self. Now, children by age of 6 are ready to adequately process, cognitively, the skills and functions required for managing the CIC and SC. And if it is introduced early at age and normalized as a part of their routine functions, and are explained or maybe given an opportunity to talk about the rationale behind it, behind the procedure and the management, and are made aware of the benefits, they are likely to adapt much better. This is also going to give them a lot of sense of control and participation in their own management and care. When we are looking at effective psychosocial management, we need to address the condition and the treatment on the child and the family's daily life, emotionally, socially, and practically. These are some aspects that are going to be helpful. Definitely the psychoeducation, sensitization, explaining the rationale, going back and forth with trying to understand what the child has understood, also allowing the child the safe space and opportunity to ask questions, offer a sense of control over the management of the condition, encourage their participation in their self-care. Empowering the parents and caregivers is going to be a big one here because it is going to impact the child's adapting to the condition and the management. Using strength-based approach where children and adolescents are encouraged to participate in the best capacity in all the activities that they can and they must. Building trusted inner circle of family, friends, and educators, teachers, sensitivity in their inner circle and community is going to be a huge factor that is going to help them lead a normalized life and going to encourage their social participation in the best capacity. Definitely professional support and building safe spaces for the child in the clinic, in the space, and encouraging open communication. Now, in one of the studies, it was noted that sometimes, because the nature of management and treatment is such that children require privacy and space. They were better able to communicate freely in their home space and environment, or a home care, if that was offered, rather than in a hospital setup or a clinic. So there were these aspects also that were kind of identified as to when these conversations can be held and in what setup and how they can be encouraged. Again, when I'm concluding here is with building mental resilience and the support that the child needs in the management and care of the condition. Most important protective factors are definitely the parent support, coping skills that the child is introduced and built from the beginning of time, a stable home environment, and positive experiences that can help to combat or overcome or reduce the impact of the management of CIC or SC. Thank you so much.
Thank you, Dr. Sachi, for that wonderful talk. Any questions from the audience? Any questions for any of the speakers?
Nocturnal, enuresis, and thumb sucking. Okay. See, as far as I'm aware, thumb sucking is definitely a regressive behavior, and it could have many other factors around it, and definitely we need to look at that. Then it
of some sort of spectrum, which has kind of given rise to this behavior. So that may have a relationship to nocturnal enuresis, because both may be like a manifestation of some underlying stress. But per se, there is nothing that connects with stress. Only if they're both secondary, then we may understand that there is some underlying psychological stress.
Thank you, Dr. Nisha, for elaborating on that. Thank you.
Any other questions?
No, I guess there are no questions. Rachel, we can conclude the session and you can give the remarks.
Thank you, everyone. Thank you, all the speakers and the audience. We can conclude this session now. Thank you.
कधी कधी माणसाला स्वतः किती माळली त्याचं त्यालाच माहित नसतं. तशी वेळ येतात. ती वेळ आता आली.
कुठे गेलो मला का माहिती तू काढलंस मी काढलं हा इथे लावलं करते का
आरोग्यासाठी जे करू
तब्येतचं
त्यासाठी करू शकतो. खूप आटापिटा करून इथपर्यंत आले विचार करते.
Did you